Hello, so we are going to go over today acid, base, and some fluid therapy calculations. So I am going to start with our pH system, which some of you guys probably remember obviously from science class, and you may have gone over pH obviously and acid base when you were in tech school, but we'll just kind of go over that briefly again, and hopefully I'll make it a little bit easy for you guys so you're not too afraid to go over it when you're working in practice. Yeah, so we'll just kind of go over that and go from there. So when we talk about pH, pH obviously affects in multiple things. We're actually going to talk about it today rather than obviously urine. We're going to actually talk about it within the blood. So in the blood, we're looking at the pH, and actually a pure water pH is 7.0. That's neutral. So our blood is actually more alkaline than our neutral pH of water. Okay, so our blood pH, our normal is 7.35 to 7.45. So that would be, like I said, more on the alkaline side. However, when we are talking about if our patient is more alkalotic or more acidotic, if they are less than 7.35, they are going to be more acidotic. So going towards that 7.0, they're going to be more acidotic, so towards acid. Or if they're going further away from the 7.45, so greater than 7.45, they're going to be more alkaline, so basic. Okay, so that's kind of that little scale right there. And so there are a lot of factors that go into this, and so we'll talk briefly about it, but we won't go too much into it. And you know, our body system really tries so much to compensate for that, but a lot of times, you know, patients get obviously really, really sick, and if they get really, really close to that 7.0, death could occur, obviously. I've seen patients be, you know, at 6.9, 6.8 in emergency, and they're really, really sick. So we really have to check these blood values and really intervene as much as possible. And fluid therapy is part of that. And so this is really important for us as technicians to also understand and know how to evaluate them, and then also understand why they're compensating for this too. So there are two different systems that we're looking at, whether it is metabolic or respiratory as well, so that we can determine that. So right now, we kind of know the normals, right? So we know our normal pH for blood is 7.35 and our 7.35 to 7.45, right? And so we know that if we're going towards that 7.35 or below, it is acidotic. And if we're going above that 7.45, we're alkaline. So we're going towards that basic. So that is great. Then we can determine right away acidotic or alkaline. So that is the first step in solving any type of problem, right? Is looking at our pH. So that is step number one. So our next step is looking at two different values in our blood. So we are looking at our CO2, and then we're going to look at another thing that is called the HCO3. So that is called our bicarb. So you've probably heard of bicarb before, or even heard of bicarbonate, which is an injectable drug that we use at times, right? We use bicarbonate for many different purposes, but in this case, we're looking at it within the blood. So bicarbonate is what our metabolic value is, right? So our CO2 obviously is going to be our respiratory, right? It's because we're breathing off CO2. So that's our respiratory component. And so when we look at CO2 and our respiratory component, if we think about our anesthetic value, right? Our anesthetic value when when we are monitoring them under anesthesia, we want them to be 35 to 45 millimeters of mercury, right? That is our normal range. Well, that doesn't change in our blood either. So their normal range is 35 to 45, right? So that is something that makes it really easy to remember for this problem too, right? Is that it's 35 to 45. And then if we look at it with our pH, that is also 7.35 to 7.45. So we can say, okay, all we have to remember for the pH is that it's 7 point, and then the 35, 35 to 45. So respiratory obviously comes from the lungs. Okay, so it is a respiratory component. Now the bicarb's a little bit different. Okay, so there's not something that we can really remember the normal range for. We just have to kind of remember and put that in our brain. So our normal for the metabolic or bicarb is 22 to 26 millimeters of mercury. But if our bicarb is not correct here, right? Our bicarb is abnormal here, then we have a metabolic issue, all right? And so the metabolic issues are coming from our kidneys, okay? So that means that something is off within our body system here, right? So we have to give fluids this way. We have to fix something that way, all right? So in this case, whichever one is incorrect, whichever one is not normal within the system is the winner, right? So if our CO2 level is 36 and our bicarb is 28, that means we have a metabolic issue because the bicarb is the one that is not appropriate in this case, right? Now, we can have it where, our CO2 becomes elevated if the bicarb is extremely off. And many times this happens in cases where we have maybe a DKA that comes in that's very, very extreme. And the DKA is a metabolic acidosis. And so sometimes that's called compensation. So the body is trying to compensate. And so this becomes one of those things where down the road, you guys will learn a little bit more about acid base. But one thing I learned, and I was a very, very young technician, was that we had this DKA that came in and it was panting like crazy, right? And so I was convinced at the time that this DKA had to have been oxygen dependent. And because it was just panting like crazy. And I kept checking the SpO2 and the SpO2 was normal. And I couldn't believe that it didn't need to be an oxygen because it just looked like it was oxygen dependent, that it was having a hard time breathing. But really what the case was that the animal was trying to fix its pH, and also the bicarb was so significantly off. So the body really tries to compensate for itself during that time. So yes, we were helping in the instance of actually diuresing the kidneys and giving insulin and all of that. But the body was also as well trying to compensate by breathing heavy as well. So it's pretty interesting how that all works. So why do we need to know this, right? So just kind of like I said, we need to know this so that we really know what's going on with our patients, right? We need to be able to understand why our patients are acting the way that they are, so that we don't do anything to hurt what our diagnosis is. So we know how to diagnose our patients. So we know how to treat them appropriately, right? So we can relay the message to owners and give them great quality care. And so the more information that we learn and know, the better support we can give to our patients and to our owners. So this is really, really important. So really, what are some things that we can do, right? So we need to maintain hydration, replace that fluid deficit that they may have, give them, replacing those ongoing losses. So we're going to learn those calculations of how to do that. So we have to maintain that hydration that they would be getting, throughout the day, replacing any deficits. So if they're dehydrated, if they had any ongoing losses, so were they having any vomiting or diarrhea, anything to that nature, any significant, extra urination that could have been going on, treating decreasing onconic pressure. So was there any decrease of blood pressure that we need to treat, right? And also hypovolemia. So decreasing onconic pressure would be, hey, do we need to give them any colloids? And then hypovolemia, do we need to give them any crystalloids as well? So there's a good balance between those. Treating shock states. All right, so many different types of shock that we need to treat at times. And so there's many different types of treatments for those types of shocks. So recognizing shock and what shock we're treating, okay? And then improving and increasing urine production. So knowing what normal urine production means, and then also how to measure it. So if we have a patient on IV fluids, especially, we need to be measuring urine production at all times. So as a veterinary technician, we need to know how to measure it. And there are many different ways. So we need to be weighing our patients at least once to twice a day, at least. We need to be measuring their urine of either subjectively, of either measuring it if they have a urinary catheter, we could weigh it if it's on a pee-pad, and we also could be checking a specific gravity of their urine as well. So many different ways. And then correcting acid base or electrolyte disorders, right? If we are going to be giving them fluids, we are changing their electrolytes because we are going to be diuresing them, and those electrolytes are going to be diluting down. So many times we're going to need to be supplementing those electrolytes over time. So it's very, very important that, yes, acid base comes into play, right? And when we check it once, we're going to have to check it again. But we also need to check electrolytes right away, see where we're at as baseline, and rechecking those electrolytes multiple times after giving fluids is very, very important, because if we have an electrolyte disorder, we're going to need to replace those. Otherwise, we're going to be running into trouble too. And then maintaining that IV access is really important. And then delivering any of those other medications that the patient might have, right? Especially if they're not eating or we can't feed them right away. We're going to need to give medications through an IV or if it's sub-Q or any type of different methods. So it's important to have great IV access. So types of fluids, I want to go through some of these because it's important that you guys know our standard fluid calculations of that you're going to have to know to do these math problems. So we're going to just go through like our colloids and crystalloids so that you know exactly which ones that we're going to be talking about, and then what are our fluid rates and stuff like that for each of those. So it's really important that you guys know these by heart. It's also a good idea to maybe put these in like a little notebook that you can carry around with you until you're pretty confident in knowing all of these. So when we talk about different fluids, we have crystalloids and we also have colloids. So crystalloids are the types of fluids that you would essentially drink every day. So like more of your water-based fluids, right? So they're little, think of crystalloids, like little tiny molecules that just go through vessels, you know, we're keeping everyone hydrated with, right? So we have sodium chloride, we have plasma, we have LRS, normal salt R, you know, those types of fluids. All right, our colloids are things we definitely don't want to drink unless you're like a vampire, right? So our natural colloids would be like your blood products, so whole blood, packed red blood cells, plasma, and you know, if you do like platelet-rich plasma, if you have albumin, if you have, let's see, cryocipitate, stuff like that. We have synthetic colloids too. And our synthetic colloids are like hetastarch, beta starch, and then we also have oxyglobin. And oxyglobin we currently don't have in the United States. It was on the market way back in the day, probably around like 2007, somewhere around there. It was taken off of the market. They currently have it in the UK, and it is synthetic bovine blood, which really was great, especially if you didn't have whole blood or packed red blood cells, and you could just keep this on your shelves if you needed it, especially for like type B cats or AB cats. You could use it in a pinch, but we currently don't have it approved. So it's one thing that may come back, but we currently don't have it in the United States, but it's good to know about. So in our crystalloids, we have different types of crystalloids that we use. And we have hypotonic, right, crystalloids. We have isotonic crystalloids and hypertonic crystalloids. So these are really important also to know because we do talk a little bit about these in some of our calculations. So hypotonic crystalloids, essentially what they're going to do is that they're going to pull out fluid out of your cell. All right. So we typically don't use these too much, but there are times where we essentially would use it. So essentially that would be our 0.45% NaCl. But like I said, we don't use them too often. Our isotonic, that would be our 0.9% NaCl. And so that is just keeping everything the same, you know, within our blood. All right. That's our normal salt R, LRS, plasma light. And then hypertonic. All right. So that's the greater amount of osmolarity within the blood. So it will help draw out the fluid out of the cell. So essentially, what that is going to do, and I think I talk about like brain injuries, right? So essentially what it is doing is that it is taking the fluid and it is, so if you have like a brain injury, there's a lot of swelling within the brain. So when we talk about drawing fluid out of the cell, is saying the fluid out of like the the tissue of the brain, right? And is bringing it back into the vascular space, okay? So, and so this is where people get a little bit confused because they think out of the blood cell. And so it's not the blood cell itself, it's out of the tissue of where you want the fluid to come out of. So it's taking that swollen brain, right? And it's drawing the fluid out of that and bringing it into the vascular space, because hypertonic saline means a lot of salt, right? So think of eating a bag of chips and then you really want a lot of fluid, right? So you need that fluid to come out to attract it to that salty space, right? So we're taking that fluid out of that brain and bringing it to the salty space of the vascular space. So that's essentially what it does. All right, we need to get the fluid out. So what happens is when we have this brain injury, if anyone's ever seen a brain injury, is that their mentation is really, really off. And so it works fantastic because their mentation does improve pretty quickly, all right? And so with hypertonic saline and with oxygen, they do really well many times. So if we look at it with hypotonic, what happens is the opposite, right? There's not that salt content. In fact, there's little salt content. So essentially, it's drawing the fluid to the tissue, right? So we need a fluid to go into the tissue. So we're providing water in greater proportion so it can go somewhere else, okay? So that's the difference. It's the actual opposite. So with colloids, they tend to remain more within the vascular space. The reason for that is it is there to plug up the holes of the vascular space, okay? So with crystalloids, like I said, they're really tiny, tiny molecules, right? And so they can seep out of the vascular space. If we didn't have colloids, that's what they would do, is they would seep out everywhere. So we need those colloids to kind of plug up those holes, and so that the crystalloids can stay in the vascular space and keep our blood pressure up, right? So we have natural colloids, which is our blood products, and then we have protein and stuff like that to like plug up those holes. And then we have synthetic colloids to kind of help within that too, to kind of build up our vascular space if we need it. Because sometimes we don't need to, always use natural colloids, especially since there's risks that go into it as well. So sometimes we just use synthetic colloids to kind of build up for our blood pressure and stuff. So we use head of starch and beta starch. If we have to resuscitate a patient, we do use colloids many times because we can use a less amount of colloids than crystalloids. And we also need to make sure that we're plugging up those holes to be able to keep that fluid within that space. So that's why I wrote in there that we use it during resuscitation. And then we'll also learn the shock doses as well. So back to the basics, right? So we're determining our maintenance rate. So here we have our old school maintenance rate of crystalloids, okay? So you probably heard our old school maintenance rate is 60 mils per kg per day, okay? That's pretty much what most people learned when they were in school. Now, a more accurate, and I should put in here too, because it's a little bit different. A more accurate rate for dogs, which I put the one in for dogs, I did not put the one in here for cats, sorry, is to take 132 times our kilograms to the 3/4 power, okay? And our for cats actually is 80 times kilograms to the 3/4 power, okay? So we're gonna work on those so that you guys know how to do those calculations. And the easiest way to actually do those calculations is to take, especially if you're using a simplified calculator, is to take kilograms times your kilograms times your kilograms, and then you get that total, and then you square root it, and you square root it again, and then you multiply it by, now if you have a dog, you multiply it by 132, or if you have a cat, you multiply it by 80. Now, the reason why they're doing 132 and the reason why they do 80, I'm not really sure, but that's just the formula for it. So that is the easiest way to do it within your calculator, okay? So when we talk about replacement rate, okay, so say you have a really sick patient. When we talk about replacement rate, we're taking our dehydration rate, okay, our ongoing losses rate, and then our maintenance rate. And you add them all together, and then that's how you figure out how many fluids you're going to need for that time period that you're giving, okay? So we'll do a bunch of those calculations, which you'll probably get really frustrated with me, but we'll do them and you'll get them eventually, don't worry, but they'll be great. So like we talked about our doses, so old school crystalloid doses, depending on your doctor and what they prefer to use. So some still do the 60 mils per kg per day. Some other doctors do the body surface area one now, which has been out since like 2013. So it's not like brand new, but there are still doctors that do the old school one still. So it just depends on their preference. Our head of starch dose is 20 mils per kg per day. And then our veta starch dose is 50 mils per kg per day, okay? And we can't really vary from our head of starch or veta starch dose, okay? So head of starch, just remember, head of starch is used typically for humans, okay? That's H humans. And then because it had such a low dosing for it, beta starch was made. So beta starch came out in 2009. I remember it came out. So V for beta starch. And so it had a higher dosing for it. So the reason why we can't go above that is because there could potentially be coagulopathy issues. So animals can have bleeding issues from that. And they have also found that they can have some renal issues as well too. So we have to be really cautious about how much we give. All right. Okay, so for our calculation for fluid drip rates, okay, so we're gonna do a bunch of these as you guys go along, because this one, if you work at a practice where you do a bunch of drip rates and stuff, you definitely will get really good at this, but we'll do a bunch of these over time, okay? So I'd like to introduce this stuff right away so you can just get a little bit of practice here and there, but we'll do a bunch of it. So the prescribed fluid infusion rate is 100 mils per hour, and the drip set has a delivery rate of 10 drops per mil, okay? So I'm introducing this right now, kind of in baby steps, okay? Soon I will be introducing this with an animal with pounds. You're gonna decide what, drip set you're gonna be giving, and all of that. But I'm just gonna just baby step introduce this, okay? So what we essentially do in this is that we take 100 mils, all right? And we need to change this so that we can look at this and say, all right, we need at the end of this drips per second. So the easiest way to do this is to change our hours into seconds, all right? So we need to figure out how many seconds are in 1 hour. All right. And so the very easiest way and for the rest of your life is to remember that there are 3,600 seconds in 1 hour. And how we figure that out is that we take that there are 60 minutes in 1 hour, right? And then there are 60 seconds in 1 minute. And so if we take 60 times 60, that means there are 3,600 seconds in an hour. So if we then say, if we take that hour and we substitute that hour with 3,600, and then we say, all right, 100 times the 10, right? Divide that by 3,600. We now will be able to get our answer, right? So 100 times our 10 divided by 3,600. And so our answer then, we got 0.2777778 or whatever, right? So that would be drops per second. So now we need to find out, we have to get a whole number for this, because we can't just say that it is 0.277777778 or whatever. So what I have done is I have to think of a fraction that's going to make this work to get how many drops per second. So I multiplied that by 18 seconds, because I knew that 0.2777777 was probably going to give me a whole number at some point. So many times students like play with their calculators to find like that whole number that's perfect and whatnot. But I knew after some experience that that was probably going to give me a whole number. So I multiplied that by 18 and it gave me 5 as a whole number. So that means that I have 5 drops per 18 seconds. And that is my answer for that one. So we will definitely be working on those so that you guys get practice on how to actually do that. So the next one is the prescribed fluid infusion is 20 mils per hour, and the drip set is 60 drips per mil. So again, we are going to take our 20 times our 60. And then remember that hour is changed to seconds. And so that means it's 3,600 seconds in that hour. So we have 20 times 60 divided by 3,600. And we get 0.33333333 drips per second. So what do we have to do to get a whole number? If you're thinking multiply by 3, you are correct. So that means we have 1 drip per 3 seconds. Very good. All right, so signs of fluid overload. So if we get it wrong, right? If we round incorrectly, you know, if we aren't like in the last the problem before the last one, if we cut the corner and don't round correctly, you know, and change our fluid rates where we don't round right, we start fluid overloading our patients, which is really, really bad. So we have signs of chemosis, which is essentially what you see in this picture here. I just love that word, but I hate what happens. And so you see the conjunctiva of the eye just swell up. You see dripping from the nose, you see panting from your patient, you hear crackling of the lungs. And so our first thing that we do more than anything else is you stop all fluids. That is the absolute first thing you do. Before you call over a veterinarian, before you start freaking out or whatever, you stop the fluids and then you get the vet, right? So most of the time they're going to stop the fluids, going to give a diuretic and go from there. But it is very, 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 very important that you stop the fluids, even if you're not sure, right? You're going to stop the fluids because you know I start them again. So, but you stop the fluids. Okay, so now we talked about how do we know how much fluid or urine they should be producing. So adequate hydration should be 1 to 2 mils per kg per hour. Okay, so we're gonna check for their urine specific gravity every 4 to 6 hours and looking for trends. Okay, so if their specific gravity is like overall just changing like crazy, then we need to do something about it, right? If they're starting to gain a ton of weight, that's not okay either. Now, if they were really, really dehydrated when they came in and now they're like starting to get hydrated by gaining some weight, that makes a little sense. How much does 1 pound weigh in mils? If you're thinking 500 mLs, you're correct. So very good. So additives, important additive that we have to remember is KCl. So KCl is a very, very serious additive that we have to monitor very closely. If we give it too fast, we can absolutely kill our patient. They have arrhythmias and they die. There have been ER episodes that have shown that they've killed patients, if you're old like me, that have watched ER where they kill patients with KCl. I mean, I've actually personally seen, rather than giving euthanasia, that people have used KCl instead. It is not very, not the best way of using a drug for euthanasia solution without any pain management, at least on board, or not being under anesthesia. But the majority of the time that I've seen it, they have been at least under anesthesia. And I have seen an animal die from overdose of KCl before. So we should not be given patients KCl any faster than 0.5 milliequivalents per kg per hour. This is very, 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 very important information for you to know. Many times when we have a pH that is less than 7.1, we do supplement with sodium bicarb, but we have to be really careful that we don't give too much too fast. So we don't want to raise their pH too fast. So we do just kind of supplement slowly and making sure that, we're just kind of baby step bumping them up. And then another additive that we give many times, of course, is dextrose to ensure that we're keeping their glucose elevated and high if they need it. So We're going to be working on some calculations for dextrose in their fluids too. And then another way to measure blood pressure and then also hydration is by doing CVPs, especially when working in, an ER facility or any specialty facility. But you can even do this obviously in a general practice because honestly, jugular catheters really aren't as difficult to place as you think, especially if you can keep them clean. So they're done through a jugular catheter or a central line, whatever you'd like to call them. Normal for that is somewhere between 0 to 10 centimeters of water, but you're just looking for trends as well. So that is that. And that is all I have for you guys today. So thanks for joining me. This is a great introduction to acid base and fluid therapy. And we will talk soon. Take care, guys.